Very kindly, Brian came to give us an in-person presentation. You can see his title here. I think it's an engaging one. Is this asthma or not? Making an accurate asthma diagnosis in adults. It's sometimes a very challenging question. So I think this should be an interesting presentation. Thank you.
Thanks, Len. Appreciate it. Thanks everyone for being here. It's great to give this talk in person. This will be my third talk at this conference, as I said before. First time doing it in person, which is always a pleasure. And the reason that I chose this topic, we'll get into some of the details of it. I truly find this to be the most challenging thing that I have to deal with on a daily basis. I see patients primarily at Northwest Hospital. I have an asthma specialty clinic up there, which means I get referred patients to other providers or patients themselves think they have asthma. We'll talk about kind of how frequently that happens, but I do find that seems to track pretty well, that about a third of patients are probably incorrectly diagnosed, at least by the standard criteria that we utilize or that's recommended by now. We'll talk about how standard that criteria is and whether or not we all agree with it. The hope is that this is going to be a little bit more than more of a lively discussion amongst the group, rather than kind of a formal lecture. I certainly have content that I want to get through. I have also case presentations that will kind of apply this content to. I'm really interested in the group's thoughts on kind of what is asthma, and how we all think about it, trying to put together kind of a shared model. So it's here. I don't have anything to disclose really relevant to this talk. And I think to start, I'm certainly very interested in the biological underpinnings of asthma. I spend a lot of my time doing basic and translational research in this area to try to find kind of key novel targets in asthma and how to develop new therapeutics for patients who still have uncontrolled disease despite the medications we have in our armamentarium already. And so to that end, it brings me great joy putting together these kind of complex figures with different exposures and cell types and cytokines going all over the place, these different inflammatory endotypes. And I also, very much enjoy, applying or ever expanding armamentarium of biologic therapies and engaging in this discussion of which biologic therapy may be best for which patient. And it's something that I encounter in clinic on a daily basis. I think the people would find, probably about 1 in 5 of my moderate to severe asthma patients are on a biologic of some kind, and I use all of these medications with some frequency. But looking back in the speaker list for this conference over the last couple of years, it's really been a who's who of asthma experts, and there's been many talks about different asthma biologics, how to apply them, talks on novel therapeutics in asthma, and far be it from me to think that I can provide much more information beyond that discussion that's already been had here. But I think what I found most consistently, and still what I would say, hopefully it's still a very young career. I've got a little gray hair creeping in here, but not much, at least yet. But to that end, I find asthma therapeutics work really well on patients that I'm pretty confident actually have asthma. I find it so much more challenging to apply asthma therapeutics to patients where I go, God, I don't know, that lung function testing doesn't really fit. There's things about the story that just don't quite add up. I'm going to try, asthma-directed therapy, but I don't know, I'm not going to be shocked if it's not working. And I think, I hope I'm not alone in that. I find that this is by far and away the most challenging thing. Way easier to give somebody dupilumab who's got nasal polyps and high EOs. I know they're going to get better on that therapeutic. I'm not so confident that's going to happen in patients with EOs of 155 and normal lung function who just have frequent symptoms. And so my prior talks in this conference have focused on diagnostic testing in asthma. And back in 2021, I talked about airway hyperresponsiveness testing in asthma and how to properly apply methylene challenge testing and exercise challenge testing to make the diagnosis. And then a couple of years ago, I talked about the fraction of exhaled nitric oxide and how best to utilize it in diagnosis and management of asthma. And so I think, again, trying to get back, asthma, I think, is quite a challenging thing to diagnose, and we'll talk about the reasons why, but how big of a problem is this? We commonly overdiagnose it all the time. These are the results from a very well-cited study, a cohort study in Canada, that found among about 700 patients with a physician diagnosis of asthma in the last 5 years, half of them never really had any diagnostic testing for asthma. They really had a clinical diagnosis of asthma, and they never had any kind of airway physiology testing of any kind. They took those patients over the course of the next 12 months and then did some intensive diagnostic testing for asthma. A third of them did not have any evidence of asthma and really should not have been on asthma-directed therapies. That doesn't surprise me. It's a very common thing that patients get started on albuterol inhalers after they have wheezing after a virus or go on cough after a viral infection. That asthma diagnosis has some stickiness in the chart. It tends to stay there for quite a long time. Amongst those, the group that did not have asthma, I think most concerningly is 2% of the overall patient population had really serious comorbid conditions that were not being identified. 2% had ILD, coronary artery disease, sarcoidosis. These are diseases that do not respond to asthma-directed therapies and require very different management strategies. But paradoxically, on the other side of the coin, asthma is also underdiagnosed. And so this is a study in Denmark where they sent a screener to 10,000 patients in the general population, screening for symptoms of asthma and rhinitis. About 1,100 people screened positive. They took this group of 1,100 and then over the course of the next several months did some intensive diagnostic testing for asthma. About 500 of them did have the diagnosis. But maybe most interesting of all is that 2/3 of these patients were previously undiagnosed with asthma. And you think, well, I don't know, these are maybe mild severity symptoms, mild severity disease. No, about half of the patients eventually would be categorized as moderate to severe asthma, and they were going untreated. So I'd say if we're overdiagnosing it a third of the time, and then missing it in the general population with some frequency, it's a tough diagnosis to make. And why is that? And I think we recognize these two things, that asthma is an extremely heterogeneous disease. The clinical presentation is very, very nonspecific, and it's very, very variable based upon the patient's own experience and what they describe in their symptoms, the symptoms that are responsible for their primary presentation. And I think most of all, there's no gold standard diagnostic study. I think we're taught in medical school, or at least I feel like I was taught in medical school, that a methylcholine challenge test is the absolute gold standard. If that's positive, they have asthma, and if it's negative, they don't. That's not true. It just is not true. If you're actively symptomatic and not on therapy, and you have a negative methylcholine challenge test, you do not have asthma. If you are on therapy of any kind for asthma and it comes back negative, it tells you nothing. Methylcholine challenge test comes back positive, you have asthma, but might have COPD, might have bronchiectasis. There are many diseases that have positive methylcholine challenge tests. There really is no gold standard study. And when I was researching this talk, I came across this great quote, which I think kind of summarizes the issue pretty well. This was a correspondence between two authors for this little editorial they put together for the Blue Journal. And one of the people in the correspondence said, asthma is like love. Everyone says they know what it is, but nobody has the same definition. And I think that summarizes it pretty well. I think we all have an idea in the clinical history we're going to get for patients when they come in and tell us the asthma story. I think we see some variability in that, but we all have kind of a fixed idea of what it is. And I think there are some that say, does it really even matter what we call asthma? If a patient comes in with nonspecific respiratory symptoms that seem like they're likely to be asthma, and we apply asthma-directed therapies to them, and they get better, haven't we done well by this patient? Is that a fine approach to it? I think maybe. That's certainly, I do it. But I don't know that it's the best policy to kind of take on the global scale. So I'll push back a little bit. And I think if we really can't agree upon precisely what it is and have a shared definition of it, how do we know that we're all studying the same disease entity at one time? We really limit our ability to have any kind of shared understanding of the biological underpinnings of disease. We're not consistently studying the same patient population. And we'll get to this a little bit later. Some might say, gosh, asthma is just too heterogeneous to really engage it in this kind of fixed criteria that's there. I don't know. Certainly the pharmaceutical companies don't feel this way when they're putting together clinical trials. They have very, very strict inclusion-exclusion criteria of what defines asthma. And if we're going to apply those same therapeutics to our own patient population, we better hope that we're trying to mimic the patients that are being studied if we're going to expect the same results. And this is across every asthma study that I could find over the last 2 decades. I picked a few of our favorites. This is the Sigma-1 trial looking at as-needed use of ICS-LABA versus scheduled ICS versus as-needed SABA. This is one of the defining studies suggesting that as-needed short-acting bronchodilators are not a recommended treatment strategy for patients with mild severity asthma. And of course, the devil is always in the details, but right here in the methods here, the patient population they select, patients with asthma had to have a confirmed diagnosis. They had to demonstrate that they had some variability in their lung function. And we'll talk about this significance criteria for 12% and 200 mils. So that's the case with inhaled therapies. Pick your favorite biologic. They all have the same inclusion criteria. This Haldar 2009 mepolizumab study in the eosinophilic asthma, quite a landmark study. They had a few more criteria for variability here in lung function. Patients could have kind of 20% variation in the peak flow rates. They had a 15% improvement in their FEV1 after albuterol, or they had a significant decline in their lung function after methadone challenge testing. Dupilumab, same thing. Patients had to have reduced lung function FEV1 that was less than 80% for the adult population. And they had to demonstrate some significant improvements following bronchodilator. So there has to be some kind of reversibility here. You're noticing here, gosh, I don't see a lot of like elevated RV to TLC ratios as inclusion criteria here. I don't see a lot of fixed airflow obstruction as inclusion criteria for these patients that are in the trial. Benra, no different. And more recently, tezepelumab, again, no different. Have to demonstrate this variability that's there in lung function. So the clinical trials we have with patients with asthma really do have these very strict inclusion criteria and relies very heavily on variability in spirometric performance. Airflow obstruction comes and goes in some of these studies as a defining quality. We'll talk a little bit about that. But at minimum, we have to demonstrate there's some variability in lung function, or at least for inclusion into these trials. Similarly, on the other side of the coin, there's very strict exclusion criteria. Patients who are heavy smokers, patients with serious cardiac disease, patients with other comorbid lung diseases and immune deficiencies, they're not in these trials. And of course, that might not be, this is not a dilemma that's only shared by asthma. Every therapeutic we apply that has some kind of clinical trial associated with it, sometimes that trial is not generalizable to patient populations we all see on a day-to-day basis. But if we're going to apply these therapies and expect the same responses they see in clinical trials, gosh, we better hope that we're at least doing our best to mimic the patient population that's being studied. And at minimum, test for it. If half of patients with an asthma diagnosis are not getting a diagnostic test for asthma, I think we're falling short. And so just a brief outline of the talk today that kind of sets up for what is the problem and what we're going to talk about. What are the definitions that are kind of currently in practice that people are commonly utilizing? We'll talk about the National Asthma and Education and Prevention Program, EPR3, 2007 guideline. There was a focused update in 2020. It didn't modify much the diagnostic criteria at all. And then we'll spend most of our time talking about the Global Initiative for Asthma 2023 update and the European Respiratory Society 2022 guidelines. We'll talk about my own recommended approach of how I would amend some of how they define the disease and some small little caveats, and then my own approach that I use in clinic that I find to be helpful. And I hope when it gets to that, at any point in here, that there's some discussion of people's thoughts that really like that, or yeah, maybe there's other things that we could add in. And then finally, we'll apply this to some real life cases of patients that I've seen in clinic over the last year. So first, starting with diagnosis. So what is asthma? How do we define it? So this is the NAEPP, EPR3. This provides not a lot of, this is of course a set the groundwork and framework for a lot of subsequent definitions. So I think it provides us a nice benchmark to work from. They define this as a chronic inflammatory airways disease, which I would agree with. It has some classic respiratory symptoms that are quite nonspecific, and it has some significant variation. Here they comment specifically on time of day for where there's variation. But they define the airway physiology criteria as evidence of variability in lung function, and that there's also airflow obstruction that's there. So kind of two criteria there that are next to each. They also say that there's an increased incidence of bronchial hyperresponsiveness, a non-to very beloved HR, but and that gets kind of lumped into variability in subsequent definitions. The Global Initiative for Asthma 2023 update to the Global Strategy for Asthma Management and Prevention expands this a little bit. They define asthma as a heterogeneous disease, usually characterized by chronic airway inflammation. And again, it has these nonspecific respiratory symptoms that are episodic, vary in time and intensity. And then they have, again, airway physiology criteria. Variability is a key component of it, and then the presence of airflow and limitations defined by restriction on spirometry. I'll talk about what those thresholds are. They do acknowledge here that airflow obstruction may become persistent. we're starting to find this more and more in patients that receive asthma, that they will develop fixed airflow obstruction. Those patients are not well represented in clinical trials, and so we don't have a good sense on therapeutics. I think they're a population of interest going forward. Certainly, we apply the same asthma therapeutics to them, including the biologic therapies. We just don't have good studies of how well this impacts their disease. The European Respiratory Society set up a task force in 2018 to better, more formally, using PICO questions and a great approach, look at the diagnostic accuracy for testing in asthma, and then put together a framework for how they recommend proceeding with diagnosis. And they have the same kind of working definition here: chronic inflammatory airways disease, has some nonspecific respiratory symptoms, and their airway physiology criteria focuses mostly on variability. They don't have strict inclusion of airflow obstruction. And I think that this mimics a little bit better of what is seen in clinical trials. Most of the time, having significant variability in lung function is enough for entry into these clinical trials for asthma. Not always do people require airflow obstruction and demonstration of reversibility. So if these airway physiology criteria are so important, let's take a look at the details of exactly what that means. So we'll kind of make a comparison on both sides here between the Global Initiative for Asthma guidelines and the European Respiratory Society guidelines. There's a requirement, there's excessive variability in lung function. And starting with the easiest one is that there's a significant response to bronchodilator on spirometry testing. And we all think of this significant bronchodilator response as being defined by this old 2005 criteria. And this is the operating definition that has been used for past and current clinical trials, where a greater than 12% increase in FEV1 or FVC, also with an improvement of greater than 200 mils, in comparison to baseline pre-bronchodilator values on that day on that test. That's been the standard for many, many years. Of course, in 2021, the American Thoracic Society and ERS published a new guideline regarding interpretation for pulmonary function testing, and they recommended changing this definition. The bronchodilator response should not be defined by the patient's pre-bronchodilator spirometry values. It should instead be in comparison to predicted values from normal individuals, basically 100% predicted value. And it's defined not by some numerical cutoff in terms of the volume that's increased, but a greater than 10% increase in FEV1. This criteria is what's going to be being produced on our pulmonary function testing reports. That the percentages may look different. If somebody's FEV1 is a liter and it goes up to 1.2 liters after bronchodilator, that would not be considered a bronchodilator response by the current recommended definition for interpretation of the guidelines. I bring that up mostly as a watch this space area. This may change in terms of how people include folks into clinical trials moving forward. But at the moment, almost everybody is still using this older definition of greater than 12% and 200.
Why they suggest a change?
Well, I think that for patients who have kind of this significance in bronchodilator response, I think it's mostly for not necessarily related to the asthma population. I think it's more related to the COPD population. Is kind of the key demographic that they're wondering about. Those are the patients who tend to have much more severely reduced lung function. The presence or absence of variability in the lung function post-bronchodilator means quite a bit less clinically, I think, in that patient population. COPD is not my primary area of expertise, but I don't, when I see people with COPD, make therapeutic management decisions based on how much they're improved after bronchodilators. Some people might say that, gosh, if you have a certain level of bronchodilator response, there's this asthma COPD overlap syndrome that we're concerned about that has a seemingly ever dynamic definition and has even more confusion. I think the idea of it here is that patients with low reduced lung function who have a modest improvement after bronchodilator response, that starts getting at the edges of statistical significance. If your FEV1 improves from 1 to 1.2 mils, is that actually any kind of like clinical significance in that change? And it also, I think, starts bordering on variability tests, particularly for people with low function.
Since you brought up the COPD asthma overlap,
Sure.
I don't know what that is. To me, it's asthmatic and smoke. What is that?
I totally agree. It changes for everyone. A couple of years ago at ATS, I was in one of these plenary sessions for discussion about what is asthma COPD overlap, and there's these different posters about it. It was funny walking around at each of the individual posters. They all had different descriptions of what the patient population was. And they even have a bigger problem than we have in just general asthma is actually can't seem to agree on what it is. In general, people would say if there's greater than a 400 to 600 milliliter improvement in spirometric performance after bronchodilators, and they have some evidence of airway inflammation. COPD clinical history tends to be patients with chronic cough, chronic bronchitis, and they'll have some kind of persistent symptomatology that maybe exacerbates during viruses. Asthma tends to have a much more dynamic course. There's been more interest of late of COPD and the utilization or the presence of type 2 inflammation in the airways of some people with COPD. And of course, there's been some therapeutic, there's some clinical trials about utilization of our asthma biologics in this population. It may start becoming a more prevalent thing where we start looking at the overlap. But the strict definitions, I think that they're pretty variable. And I think they're more dynamic than even what I'm showing here now. Great question. So a significant response to bronchodilator is one thing. We use the old definition, which is here in the bottom. When I say significance, that's going to be greater than 12% improvement and greater than 200 milliliter improvement dilator administration. You can have a positive airway hyperresponsiveness test. More commonly, we think about using a methylcholine challenge testing for this. This is well trodden ground in the prior talk that I'd done. But there are also other challenge tests with exercise, inhaled allergen, which is not commonly done at our institution, eucapnic voluntary hyperpnea. This is another test that's done here. Mannitol challenge, something else that's done here. Excessive diurnal variation in peak expiratory flow rates. This is giving a patient a peak flow meter, and then over the course of 2 weeks, having them measure peak flow rates in the morning and at night, and measuring basically the highest value versus the lowest value divided by the average. And the GINA guidelines would accept a greater than 10% variability in peak flow rates over this interval to be consistent with variable lung function. ERS would prefer that there's kind of a higher specificity threshold of bumping it to more than 20%. I personally would probably favor the higher specificity cutoff of 20%, mostly because there's so much operator error and challenge with the accuracy of peak flow rate. The last thing that I think we potentially underutilize a little bit is somebody who comes in with, say, reduced lung function that isn't meeting the obstructive criteria and doesn't have response to bronchodilators, is then putting them on asthma-directed therapies and then repeating testing 4 to 6 weeks later to see if there's significant improvement. That's a strategy that I think is accepted by both the Global Initiative for Asthma and the ERS. The ERS also specifically mentions putting people on oral corticosteroids for a 2-week course. That's really they're really diving in deep and committing to oral steroids. We'll get into some differences here between the two guidelines for how they look at the airway physiology data. GINA will accept significant variation in spirometric performance between visits. So if there's greater than 12% difference in the FEV1 or FVC in a time-dependent manner, regardless if they're on or off therapy, they would prefer that it's not during acute illness, but they'll accept it's during acute illness. And then airflow obstruction is actually only required by the Global Initiative for Asthma guidelines. They define it as an FEV1 to FVC that's less than the lower limit of normal. Classically, right, we all were taught, at least I was certainly taught in medical school, to use a threshold of FEV1 to FVC of less than 0.7. Obstructive physiology develops as a natural factor with age. There's air trapping that occurs across the aging spectrum. The lower limit of normal for an FEV1 to FVC ratio in somebody in their 70s is certainly below 0.7 versus an FEV1 to FVC in somebody in their 20s is probably quite above 0.7. And so we should really be focusing on the lower limit of normal. The ERS guidelines don't share the same need for demonstration of airflow obstruction. They say that more or less they're going to use a more sensitive cutoff. If an FEV1 to FVC is less than 0.75, it warrants some additional evaluation for this excessive variability in lung function, but isn't necessarily a defining characteristic for the airway physiology. Is there anything else out there? Do we have any other fancy toys we can play with to help us make an asthma diagnosis? And this comes up frequently on testing. The times that we do obtain lung volumes, it's not uncommon that patients who have asthma will also demonstrate the presence of air trapping, defined by an elevated RV to TLC ratio. More recently, we've adopted changing to Z-scores, so greater than 1 Z-score above the average, which would be plus 1.65. In these guidelines predate some of the air those is the adoption of Z-scores. And so they would say greater than 135% predicted. Global Initiative for Asthma would say no, it's not a reliable thing. Air trapping happens across the age spectrum. We don't understand precisely how it is. It's not a specific feature of asthma. ERS says, well, maybe. If somebody's RV to TLC is greater than 135%, this has significant predictive value, positive predictive value for a positive methacholine challenge test. As we've kind of covered before, a positive methacholine challenge test does not guarantee that you have asthma. It means that you might have asthma. It doesn't mean you couldn't also have COPD, which also would have physiologic air traffic. This is another one. Gosh, they just think that more additional testing is going to be needed, potentially coupled with other biomarkers, where it may end up reaching their diagnostic status.
Isn't COPD more likely to have air trapping?
It depends when you catch it. I mean, certainly active asthma that has airflow obstruction is also likely to have air trapping. If you've got reduced FEV1 and FVC ratio on your spirometry of a patient who has asthma, you can have reduced values of both and still meet an obstructive criteria. If you get lung volumes on those folks, they're almost sure that they're going to have air trapping. COPD is the same. I think it depends with the same frequency. I think asthma is more dynamic in how much air traffic is present when we're going to catch it. COPD, I think it's a little bit more pervasive, that it's like consistent with physiology. Chest imaging studies, of course, there's been a lot of studies looking at MRI, hyperpolarized helium and things like that. PET scans looking at local areas of inflammation. This has been used to kind of guide some studies of bronchial thermoplasty to identify areas with kind of heavy smooth muscle burden. Similarly, even just getting a CT with ILD protocol, we're getting expiratory cuts and seeing the presence of mosaic attenuation and air trapping. That's a long-winded way of saying no. It doesn't, not specific enough. It's not recommended as part of the diagnostic evaluation. Biomarkers of type 2 inflammation, get these all the time. Fraction of exhaled nitric oxide, blood eosinophil levels, serum IgE. GINA would just say no. It's not helpful in establishing a diagnosis of asthma. I think FeNO requires a little bit more evaluation. There's just not enough data to support it as an initial diagnostics test as a defining feature of asthma. ERS, it varies a little bit here. This is a key difference. Maybe. Blood EOs and serum IgE, no, not specific enough for asthma. Certainly important in phenotyping patients who have an established diagnosis, but not in the upfront diagnostic evaluation. FeNO, ERS actually says yes, this should be part of the initial diagnostic assessment. And if it's elevated above a certain threshold, even somebody with normal lung function, that would be enough for them to say the patient is so likely to have asthma that they should warrant treatment. It comes with a caveat. So this is actually the diagnostic algorithm that the ERS put together. And we start here with getting spirometry here. And again, their airflow obstruction criteria is less than 0.75. But let's say spirometry is totally normal and there's no bronchodilator improvements on it. Path 1 here is actually getting a fraction of exhaled nitric oxide, and it's above this threshold of 50. The threshold was debated quite considerably amongst the group that was this task force. They were debating between 40 and 50 as the threshold. 50 was thought to be specific enough to warrant being used in this way. So they would say if you get normal spirometry, classic symptoms, and a FeNO greater than 50, this is asthma and should be treated as such. They're very quick though to counter with a high FeNO does not in itself define asthma. It isn't. We certainly know patients who have low FeNOs who have asthma. We have people with high FeNOs who don't have asthma. People with significant allergic rhinitis, eosinophilic bronchitis. All of those people can have elevated FeNOs despite. So it should be used in the initial assessment. If it's elevated and a person has classic respiratory symptoms, ERS would say it's sufficient for the diagnosis, but it's not a defining characteristic of the disease. Just suggests that asthma is a much, much more likely diagnosis after you do that test and get that result. What if the patient's already on therapy? Gosh, this is all fine and good if my patient, is showing up on as needed albuterol like they have been for years. But of course, in all credit, to this adjustment and guidelines, we know that as needed use of albuterol is not a safe management strategy for long-term management of patients with even mild severity asthma. And the patient should be on inhaled corticosteroid therapy, either intermittently or as a scheduled treatment. That is going to make it challenging for us. So when patients come to our subspecialty evaluations, more frequently, I think we're going to see them coming to us already on inhaled corticosteroids. Oftentimes appropriately so, but also oftentimes without any diagnostic evaluation beyond a clinical history. They went to the emergency department with acute exacerbation. They get prednisone. Before they would just hand them an albuterol inhaler and send them on their way. Now I encourage emergency department providers and residents and interns that I, attend for when I'm in the medical ICU. I encourage them to hand out inhaled corticosteroid-based therapies for the patients with asthma. We can sort out the diagnostics later. It's more important that we keep them out of the emergency department, keep them safe. But of course, it makes our diagnostic testing more challenging. If somebody's on therapy and have normal testing, what does it mean? Well, it means that if you're going to be sure that the patient actually has the diagnosis, you better de-escalate their therapy and repeat this. And one thing that's kind of consistently, I sometimes have patients that even they're on therapy and they're terribly, terribly symptomatic, then I will test them for asthma, either with peak flow rate monitoring or with spirometry, and both come back without any variability. They're stone cold normal. Patients with active symptoms that don't demonstrate these physiologic principles, the chances that they have asthma is very, very low. It's probably not asthma. And you should keep backing them off therapy and start looking for other comorbid illnesses, things like inducible laryngeal obstruction. I myself struggle with this all the time. I have patients who are so symptomatic. Every time I try to make the smallest change in their inhaler, that they're sending, me a questionnaire, asking me for prednisone for an acute exacerbation, even despite giving them a peak expiratory flow rate monitor that says that peak flow rates are normal. It's a very challenging thing to hold the line, and I myself, it's something that I need to get better at for these patients who I'm not convinced they've actually met the diagnostic threshold. So kind of bringing it back together, I think that there's some people would say asthma is just too heterogeneous to fit into this box. I have patients who aren't really well reflected in the airway physiology testing criteria that you've described. And so I think that might be true. There certainly are patients who have chronic episodic respiratory symptoms that sound a lot like asthma, and maybe they even will be considered in this bucket that we call asthma. But I would push back that that's the approach that we should have. We have to pick some criteria for which we're going to identify patients that we're going to study, understand the basic underlying mechanisms of disease. And if we're going to enroll patients in clinical trials like we have been for several decades, we're already doing this and having very strict inclusion criteria and exclusion criteria. So if we want our patients to respond in the same way, we should actually be doing our best to confirm that they actually have the diagnosis that mimics the population that's been studied. And I'm not necessarily saying that we shouldn't be handing out asthma-directed therapies for people who we suspect have asthma, who aren't quite meeting these thresholds. If they're getting better on therapy, maybe that's enough. But it's important to note there are some people with asthma-like symptoms who do respond to our asthma-directed therapies. That doesn't necessarily mean they have asthma, and it doesn't mean that we should be expecting that they're going to have the same kind of clinical efficacy that we've defined in some of our larger trials. So we talked about the kind of definition and kind of the current approach to diagnosing asthma, weighting heavily on assessment of airway physiology data. I'm going to talk about my own little revisions to this, and then we'll go through some case presentations. But I'm welcome to hear comments, questions from anybody.
I just have a question about the guidelines. So in the US, we were having repeated updates of the expert report.
Mm-hmm.
Have we sort of, are Americans in the global initiative, or are we relying just on the Europeans to define asthma?
It's a good question. I think it comes back to that quote, asthma is a lot like love. Everybody has their own definition for it. And I don't know that anybody's precisely following any one or the other. This is something that I feel pretty passionately about, that we're trying to get programmed at the American Thoracic Society to actually put together a task force to put together a strict criteria for diagnosis of asthma. And I'm hoping that comes to fruition soon, because there's a lot of interest, particularly amongst, even, my colleagues that are more general pulmonary medicine. How do you go about diagnosing asthma? How do we're all pulmonologists. This is the most common respiratory disease in the world. We don't have a shared definition of how we diagnose it. It's frightening. I think most providers in the US would probably rely on the Global Initiative for Asthma guidelines. The EPR3 does have a focused update in 2020. It does address some questions like fractional exhaled nitric oxide. In general, I find when I'm talking to people in the US, they're typically using the Global Initiative for Asthma. The ERS guidelines, when I bring them up, oftentimes people haven't heard of them. Mostly because maybe we're just more US centric and we're not reading ERJ for the same purpose. I spend more time on it because I think they do a little bit more airway hyperresponsiveness testing in Europe, which is a little closer in line with some research. So I'll talk about kind of my revised definition here for asthma. And so I would say that asthma itself, probably, if you're going to define it as this broad bucket of so many different clinical presentations and inflammatory endotypes, it's probably more of a clinical syndrome that there's not one distinct defined pathway. There may be a final common physiology that's present, but it's probably more of a clinical syndrome composed of many individual diseases. And it is a disease of chronic airway inflammation, but importantly, it's not the only chronic inflammatory airway disease. I see this time and again in my clinic that they're getting asked to put people on biologics for other inflammatory airway diseases that are not asthma. They have these classic respiratory symptoms that are present, but isolated dry cough is rarely due to asthma. There's usually another cause of it. This idea of cough variant asthma is certainly something that's there, but there's usually more than one symptom. I can't stand the term cough variant. Airway physiology, I'll settle for one or the other, either significant variability in lung function or the presence of airflow obstruction. But you got to have one of the two, preferably. So my approach, do they have a good story? I get a clinical history, does it sound like asthma? Things that increase my post-test probability after I get a clinical history, more than one classic symptom with significant variation in response to a trigger. This is well-trodden ground amongst this group. We know how to get this history. Comorbid conditions that are associated with systemic type 2 inflammation significantly increase the post-test probability that they have a diagnosis. Nasal polyps, eosinophilic esophagitis, atopic dermatitis, all increase the chance that these episodic respiratory symptoms will. And then one thing that I also ask is that I like to see patients, if they have an acute exacerbation, if they get treated with oral corticosteroids and they respond briskly within 24 to 48 hours of this, that increases the post-test probability of the likelihood that this is asthma. Again, not all types of airway inflammatory endotypes respond briskly to steroids in asthma, but certainly the patients with T2 high asthma tend to respond quite briskly when they get exposed to oral steroids. And then for their objective evidence of airway physiology that's seen in asthma, again, I just start with getting spirometry pre and post bronchodilator. If that doesn't confirm the diagnosis, I give them a peak flow meter. Then something very commonly done in pediatrics. Maybe I'm the only adult pulmonologist who hands out peak flow meters with the frequency. I think about 70% of my asthma patients have a peak flow meter. If that ends up being non-diagnostic and there's no variability over the course of a 2-week period with kind of diurnal charting, if they're symptomatic and they're off therapy, this is a great time to get a methylcholine challenge test, because the chance that a patient who's actively symptomatic, has normal lung function and no variability in peak flow monitoring, the chance that they have asthma is very low. And if you get a methylcholine challenge test and that's negative, they do not have asthma. I can't guarantee it. If they're on treatment, which is a more common the case, when you see them, you really got to de-escalate them off therapy. And this can be a difficult thing. A lot of people have been escalated in high-dose ICS LAVA. They've had a LAMA added on. Getting them off therapy is going to be challenging. We're going to slowly back off. The Global Initiative for Asthma has a really nice algorithm on how to approach this. And I've listed kind of the reference for it here. It's kind of box 360. It's kind of the graphical representation.
Now, do you not use exhaled nitric oxide measurements in your own clinic?
I do. Frequently. Every this for the Teal Holmstrom, my research mentor, he was kind of the senior author on the FeNO guideline management, which gave me the great opportunity to get to write the summary of the document. And so I recommend that everybody use FeNO in their initial diagnosis for asthma. I tend to lean a little bit more toward the patients with the ERS, that patient has a FeNO greater than 50. It significantly increases the chances that they have asthma. But I still do my best to define some airway physiology criteria, particularly for the patients that I'm worried have significant allergic upper airway disease, because those are the people where you can get a false positive for FeNO. So I use it in everybody, but I don't use it for this airway physiology criteria. I really, really require, if somebody doesn't meet this airway physiology criteria, they will forever be in my notes suspected asthma. And I specifically list why they are not met the diagnostic criteria.
This group here on the right, on treatment for asthma, strikes me as a group with a high likelihood they're being overtreated.
Yes.
Yes.
Yeah.
And then to get them to believe they don't have asthma, or their primary doctor that they don't have asthma, and get them down on medication, I see that group a lot as a problem.
Similarly, I think it depends on the patient. I've had some success using peak flow meters in this way, that patients who are frequently symptomatic. I mean, it's very anxiety provoking not to be able to breathe. And so anxiety is certainly a very frequent comorbid illness in patients who have asthma. But sometimes the mind plays tricks on the body and vice versa. And so I like to hand out peak flow meters to patients and say, gosh, when you're feeling really symptomatic, check your peak flow rates. If it's the same when we were in clinic the other day, the chances that your symptoms right now are due to airflow obstruction that's going to get better by giving you albuterol is very low. And maybe you should just wait a little bit and try to just take a couple deep breaths and kind of calm down and then go from there. And I've had some success getting people off therapy with that. I've had to go the other way a time or two where people have been very fixated on their peak flow rate and measuring it like, twice an hour. And they send me a spreadsheet with, 30 different documented values a day. And it's a little too so it can go either way. And eventually people would say, oh gosh, why don't we just get a methylcholine challenge test? The sensitivity for a methylcholine challenge test is not sufficient enough for patients who are on inhaled corticosteroid therapy to move forward with it to rule out asthma. Methylcholine challenge testing is a test to rule out asthma. It doesn't rule in asthma. It can be highly suggestive of it, but it doesn't confirm the diagnosis. And so you want people off inhaled corticosteroids and asthma-directed therapies for at least 4 weeks and preferably 6 weeks if you're going to get a methylcholine conditions. So good story. They have the objective evidence. And the third thing in which they probably discussed a little bit more explicitly in the Global Initiative for Asthma and ERS guidelines is, have we ruled out other diseases that mimic asthma? There are just too many of them out there, and I see them in clinic all the time. So we'll talk about some individual case presentations and maybe we'll highlight these things. So the first patient, this is a common referral from a primary care provider, and these are all real patients of mine. First one will be a patient referred from primary care. The last three are all going to be referred from subspecialty providers in asthma, immunology, pulmonary, for kind of management of asthma. So 22-year-old healthy woman, she's got a dry cough, shortness of breath with exertion for the last 2 years. Things got a little bit worse after an upper respiratory tract infection a few months back. She's actively symptomatic. Her PCP made a clinical diagnosis of asthma, started her on albuterol. The patient thinks this is helping her. She in the background has some mild rhinorrhea and sinus congestion, which is a chronic issue. You get some lung function testing on her. It's totally normal. There's no variability after bronchodilator administration. She has a chest radiograph as part of her evaluation. It's normal. So let's go through the approach. Good story. It's a reasonable story. Non-specific respiratory symptoms got worse after a cold. It's not the best story in the world. It's not, they have nasal polyps and atopic dermatitis and, they're coughing, wheezing, but it's an okay story. Do they meet the airway physiology criteria? Not yet. And then we ruled out other diseases. Well, we'll get there if we kind of more look at the airway physiology. So not meeting the spirometry criteria. I gave this patient a peak flow meter and had them record the peak flows over 2 weeks. No variability at all. This was non-diagnostic. She was very convinced that she had asthma because she was still very symptomatic. She was off any inhaled corticosteroids, so this was a perfect time to get a methylcholine challenge test. This was negative. She had no direct airway responsiveness to methylcholine. This patient did not have it. Her cough was actually due to non-allergic rhinitis. It resolved after she started on intranasal fluticasone. And after working things up a little bit, she had several viral infections, and she was eventually diagnosed with postural orthostatic tachycardia syndrome, which we'll note is not managed with asthma-directed therapies. They're different diagnoses.
What do you think about that diagnosis?
Oh boy. Well, I think it depends. I think it's another very challenging population. I think especially in the post-COVID world, particularly people that were worried about having post-COVID syndrome related to some of their exercise intolerance. Those are common referrals for me as well. And at least this, thought that maybe there's some kind of preload impairments for patients with this kind of exercise intolerance, which I think does exist. The therapeutics that exist for POTS, have kind of variable efficacy, and I've seen them work at times, I've seen them not. So, it's a great question. I don't have a well-formed answer. Okay. Second patient. So this is a 26-year-old woman who's sent for worsening asthma in pregnancy. She had childhood onset of very classic symptoms: wheezing, chest tightness, cough. And she started noticing her voice was acting weird in high school. She was actually called the goose for a long time because she would almost like honk when she laughed. She said her inhalers do not help. I've been seen by asthma specialists for the last 10 years, and inhaled medicines, I swear to you, do not work. And so she's been escalated all the way up to high dose ICS-LABA, and things have gotten worse since she's become pregnant. She's now like 18 weeks. PFTs, and she's had many. She's had 8 or 10 tests over the last decade. She has fixed airflow obstruction. She doesn't have any bronchodilator response, but there's a lot of variability test to test. But more recently, the trajectory has been going down and getting worse. And so the referral question to me is it safe to start a biologic therapy for this patient during pregnancy? And so, is this a good story? I mean, classic symptoms, the voice thing's a little bit odd, and inhaler is really not providing any symptomatic improvement. It's a worrisome history to get, and not classic for asthma. She's meeting the airway physiology criteria. She's got obstruction and she's got variability. Trajectory is a little bit off, but sometimes we see declining lung function in patients with uncontrolled asthma. We ruled out other disease processes. Her flow volume loop, and this is the first one she had back in 2014, showed that her inspiratory limb and expiratory limb are quite compacted. And this is a very concerning feature for central airway obstruction. You listen to her in clinic, and she's got very obvious stridor that's present. She had really never been intubated, didn't have a history that suggested subglottic stenosis, but you get a CT scan of her neck, she's got a 3 millimeter airway. And so much so that the radiologist calls you in a panic, worried about how narrow the airway is. So this patient has subglottic stenosis, does not have asthma. She got sent to Dr. Murati in laryngology. She's doing wonderful after 2 dilations. Pregnancy went forward totally fine. She's off asthma therapies. Biologic therapy would not have been the correct thing for a patient with subglottic stenosis.
I didn't think they actually posed the right question to you. The question was, does she have asthma?
Agreed. This is the question I ask myself before every patient comes in, regardless of who refers. But it was easy to get, it was very easy to make this diagnosis here. Symptoms sound like asthma, young person, subglottic very rare. Airway physiology was there. This is why I have to have some kind of approach, because otherwise you start missing these things. And I'm sure that there are patients on my panel right now that I am missing the diagnosis in, because I haven't consistently applied this in my own teaching here. Third patient. So this is a 68-year-old woman. She's had recurrent sinus infections and has a chronic productive cough that's associated with wheezing and shortness of breath. It's been present for the last 2 decades, but it's been getting worse of late. She's had refractory symptoms despite a high-dose ICS-LABA, a LAMA, trying receptor antagonist. Her prior diagnostic testing showed that she's got fixed airflow obstruction, but she's got some significant test-to-test variability. Her T2 biomarkers have been tested on many occasions. They've always been low. And the referral question is, can we start this patient on tezepelumab for severe non-T2 asthma? Is this a good story? I don't know. Certainly we see this story all the time. Chronic cough, people with asthma, wheezing, shortness of breath. Seems to check some boxes. Recurrent sinus infections, yeah, we can see that as well. I'm always suspicious of the chronic productive cough in asthma, and I like to get sputum microbiology in every patient. It also tells me whether or not patients with positive sputum microbiology truly do have asthma. That's really the subset of patients who are likely to respond very well to chronic macrolide therapy. So I get a lot of sputum microbiology testing in patients who have a chronic productive cough. She's meeting the airway physiology criteria, but have we ruled out other disease processes? And so you get sputum cultures on her, and of course she's growing Staph aureus, Pseudomonas, Stenotrophomonas. Those are bad bugs, and bad bugs associated with bronchiectasis.
Wait, is that last bug something? I don't know that name. We used to have another name for it.
No, I think Stenotrophomonas multipula is the common name. It's a bronchiectasis bug.
Behind. Do you know what that is?
Well, that very nice. See it?
All right. So old people don't know what that is.
To be honest with you, I'm starting to feel the same way with reclassified names of bacteria that I used to go by a different name. You're like, oh, what is that? Like, oh, that's what that is. Okay.
But this, I just don't know what.
Steno's a bad gram-negative rod.
All
It's highly resistant. Usually a colonizer.
That's it?
No, it might have had a different name. You get a CT of the chest in this
I'm
patient.
hazing you.
I don't know, lower lobe predominant bronchiectasis. She gets referred to immunology after some early evaluation. She's found to have a common variable immune deficiency. And so she had bronchiectasis due to an immune deficiency. And certainly there is an overlap between people who have asthma and people who have bronchiectasis. There is an overlap in that Venn diagram, but it's not superimposed circles on one another. There are a lot of people with bronchiectasis from non-asthma diagnoses. That's actually more common than not, that it's not asthma that's causing bronchiectasis. And the management strategy for bronchiectasis is not escalation of asthma-directed therapies. It's usually de-escalation of inhaled steroids, airway clearance, chronic macrolide therapy, and pulmonary rehab. This patient got all of those things, and she also got started on immunoglobulin replacement therapy. Her lung function doubled after de-escalating her asthma therapies.
But does asthma cause bronchiectasis?
In some patients, I think you would say that is asthma the underlying problem in somebody who has allergic bronchopulmonary aspergillosis? I think that's up some debate. Same thing in eosinophilic granulomatosis with polyangiitis. I think for some patients who have severe IL-13 mediated mucus hypersecretion in their airways, they can get significant mucus plugging in focal areas and develop focal areas of bronchiectasis, but it's not usually quite as pervasive. I'm always searching out another cause for bronchiectasis in a patient that I see with asthma. Oftentimes, because the management strategy is quite divergent. I'm always hoping that the patient either has nothing and totally fine, or they have asthma, because the management strategies we have for asthma are typically quite a bit better than some of these other disease processes. Last case. So this is a 61-year-old man who has nasal polyps. He's got classic episodic respiratory symptoms, dyspnea associated with exertion, cough, chest tightness, wheezing, but he's having more pervasive exertion dyspnea that's now kind of impacting his daily life. He's had 2 prior sinus surgeries and his polyps have recurred. He's had uncontrolled symptoms despite being on a high dose ICS LABA. His PFT shows that he's got reversible airflow obstruction, and his CBC shows that his peripheral blood eosinophil count is elevated. And the question, which I think is quite reasonable, is can you restart this patient on a biologic for severe non-T2 asthma, or sorry, T2 high asthma? This patient got a great story for asthma. Doesn't get much better than this, right? Nasal polyps that have been recurring, that sounds like a systemic T2 inflammatory disease. They've got biomarkers of T2 inflammation, and they've got classic symptoms. PFT, airway physiology criteria, check, check. But if we ruled out other disease processes that might mimic asthma. And this may not project totally great here, but based on the image that I'm looking at, this chest radiograph, you'll notice that there's some kind of micronodularity to the lung parenchyma, particularly in the center here, and then there's some kind of fullness at the bilateral hyla that are here. So you put this patient in for a CT scan, and you find that they've got perihilar consolidations, that's kind of shown here, and then they've got perilymphatic nodules here in the fissure, they're here, much of other small nodules that are here. I'm not showing the cuts here, but this patient also had some hilar and mediastinal adenopathy that's present. This patient underwent a bronchoscopy with an endobronchial ultrasound and TBNA of their lymph nodes. They had non-caseating granulomas in both lung tissue and in the lymph nodes. They got an echocardiogram that showed that their ejection fraction was diminished, and then they got a cardiac PET that showed that they had active myocardial inflammation. This patient does not have asthma. This patient has sarcoidosis. And sarcoidosis, even despite this diagnosis, I was asked if I could still treat this patient. I'm asked a biologic for sarcoidosis, and I said no. There's a lot that we need to learn about sarcoidosis, but our understanding of it is it's a lymphocyte-mediated disease, not an eosinophil disease. And peripheral blood eosinophilia and recurrent nasal polyps can happen in patients with sarcoidosis.
So you're left with 2 different diagnoses in this person?
No, it's the same nasal polyps. When they looked at they hadn't really looked at the path in too much detail, but prior thing, they pulled up a path from his nasal polyp biopsies and their randomized.
And what explains the eosinophilia?
Common, and it can happen in sarcoidosis.
Yeah.
So I think the take-home points here is that asthma certainly means very different things to patients and providers, and even amongst providers, it means very different things. And we all kind of have our own little niche and window into it, and it's not always completely overlapping. And I hope that I've kind of suggested that diagnosing asthma accurately, again, is in the eye of the beholder, and it's not an easy task to do. It actually takes quite a bit of work. And it's sometimes the path of least resistance is, I don't know, it's probably asthma, let's just treat it like that. That may be right for some patients, and it may be lower stakes for patients who you're just considering as needed ICS SABA, as needed ICS LABA. But for patients, when you're reaching for biologic therapies for asthma, I think we have to increase the sensitivity of our testing to make sure we're really defining that this patient has asthma. Certainly, there are patients who may have non-classical asthma by these diagnoses who might respond to asthma-directed biologics, but I don't think that should be the take-home point for this talk is try an asthma biologic and see if it helps. Try to define that the patient truly has asthma first, and then worry about what kind of airway inflammatory epidemic they may have. I think a formal definition is quite essential if we're going to understand the basic underlying mechanisms. Probably asthma is too heterogeneous for it to have a single mechanism that contributes to this final common pathway of symptomatology and airway physiology. But we better define that who those patients are by some kind of strict, consistent thresholds if we're going to study them. And then use that same. The pharmaceutical companies know this very well because they're enrolling people in clinical trials that meet these strict criteria. And they're doing that because they definitely want to make sure they're studying the right patient population. They also want to study the patient population that is likely to respond. therapy. Patients with hyperinflation on lung volumes, patients with fixed airflow obstruction, not well represented in the studies. And that's not necessarily a good thing or a bad thing, that's just the way it is. We can't expect our patients without the same criteria that required enrollment in these trials to have the same kind of responses. Airway physiology testing is essential and something that's frequently overlooked. And if people have repeatedly normal testing, you really have to take a hard look at whether or not this is asthma. And finally, asthma is not the only chronic airway inflammatory disease there's ever been. There's a lot of classic presentations of symptoms in airway physiology that can be consistent with asthma that are really not due to an asthma diagnosis, and sometimes have very, very divergent management from standard asthma. And here's our word of the day. Thanks so much, everyone, for the chance to give this talk. I hope it was thought-provoking in a way. It's not necessarily meant to be angsty, the same we need to do better about diagnosing asthma, but I do want it to be thought-provoking in a way of after we go back and look at our patient panel, how are we truly defining whether or not somebody has asthma? So, thank you, everybody.
Thank you.
You know, it's crazy to me, like in one of your initial slides, you had stated that 50% of individuals given the diagnosis of asthma haven't had proper diagnostic testing. And it seems, you know, in the US, we're always accused of over testing individuals, but actually the Europeans are doing it better. And maybe they're just targeting the right population and not just ordering lots of tests on lots of people. They're ordering sufficient tests on particular populations of individuals.
Yeah, this study population was done in Canada too, so kind of a different healthcare system, certainly, but even amongst them, clinical diagnosis of asthma, and again, how that's made. And somebody wheezes is given albuterol inhaler after they had RSV. Asthma stays in that chart seemingly forever,
Right.
And the patient has that kind of sense, like, no, I have asthma. Yeah, maybe, but maybe not.
And I agree with Glenn, like you seem to get a lot of, and it makes sense because you're at a teaching institution, a lot of referrals biologics, whereas like, it's really the real question is, does this patient truly have asthma?
And again, and it's sometimes for these referrals, I understand how we got to that road where we're trying to make these
Yeah.
decisions. I've obviously cherry picked cases, and if there are other cases that are still quite difficult that I'm grappling with, what diagnosis does this patient truly have? Maybe I just need to treat them as though they have asthma, even though they're not meeting this kind of criteria that I set out here, because you're trying to do best by the patient. But the thing to do best by the patient is to get the accurate diagnosis at the end of the day.
It's embarrassing to say that until not too long ago, we didn't have spirometry or a pheno device at the UW Montlake Allergy Clinic, and fortunately we do now. And Delauer, we have them at all locations now?
Yeah.
We have them at our Roosevelt Clinic and at East Side as well. With COVID restrictions, I suspect the clinical diagnosis of asthma has increased and there was a less reliance on objective markers just because people weren't doing testing.
I think, even the study from before was from 2017. It was enrolling patients from 2000 aughts to 2015. So I mean, it was still. I agree that you're probably right that certainly PFT labs were not functioning at a high throughput, but for the last 2.5 years they've been running pretty smoothly.
You're up at Northwest. Do you do them right in clinic yourself with ambulatory equipment, or do you use a pulmonary function lab?
We have a pheno device in clinic that we use, and I use it on every new patient diagnosis of asthma. And I use it for some patients who show it's a nice biomarker, has some dynamic features, but we don't have in-clinic spirometry. Something that we're working on. I have two thoughts and two minds about it. It's a long time to do preclinic spirometry, and waiting 15 minutes after the bronchodilator is given extends outpatient visits for quite a long time. I'm already very chatty in clinic, and I've got 1 hour meetings. I'm already running up against it. The MAs and nurses always knocking on the door. Move it. Maybe I'm just too gregarious.
On
But
the other hand, to get the answer during the visit,
Yeah.
as opposed to send them off and schedule them for PFTs and.
it's fortunately the clinic up at Northwest has some availability. The PFT clinic. It's located on the other side of campus, which provides some confusion to patients. Oftentimes they're showing up at either location for the wrong appointment. But it works out pretty well that we get people relatively quick. I have had a few people where I really wanted it at that moment because they were actively symptomatic. The pheno wasn't high, and I wanted to start them on an ICS, but I really wanted to get the airway physiology testing before I started them on an ICS. And so that, and in one of those cases, I couldn't get PFTs within the next 72 hours, so I just had to bite the bullet and start them on inhaled medication, and then drop them off. Actually, the patient did not have this.
How do you have like peak flow meters in the clinic that you hand out, or do you prescribe those?
Yep, I have peak flow meters in the clinic that I hand out. They're donated by somebody. I don't remember the precise, but we have an ample supply of them. Fortunately, I think of the providers in that clinic and the adult providers in general, it's just not a commonly used device, and it has its own problems. I'm not suggesting that peak flow meters are the diagnostic gold standard we should be relying on, but at least it's something. At least you're trying to demonstrate some variability, and I think there's a role for them for some patients with asthma. It'd be for everybody, but I think for some.
For that last case, can you get through again how you decided on getting imaging for that patient since the story happened?
I can't make a diagnosis of asthma, but it must have.
Okay. So kind of like routinely you get an X-ray on.
Everybody who
Okay.
comes to see me, who is required that they have that chest radiograph. If they have that normal chest radiograph, it depends what it is, but if they have an abnormal chest radiograph and they've got a chronic productive cough, I'm getting from the section chest imaging to diagnose, to look for bronchiectasis, and I'm getting sputum cultures on without question. I think particularly, that question of bronchiectasis and they have chronic airway infection, the management for that's quite divergent, right? Back off the ICS dose, not ramp it up. So that's the approach that I'm making. I'm cherry picking this a little bit. This patient was very well evaluated and diagnosed actually in the UW pulmonary clinic, and then was sent to me as kind of a second opinion after some of this information already kind of come to light.
So for this patient, would you have gotten a CT or just based on the history regardless? Or was it sort of the chest X-ray finding this sort of option to do that?
Is it just
Okay, to get the CT. Okay.
Are you doing induced sputum like for air and uses it routinely, or you just having people, they can expect your sputum on
It's
the.
always just sputum. And eventually there may be a world here at the university where the laboratory medicine group is interested in doing induced sputum testing for airway leukocyte populations. At present, that's not there. They're concerned about the processing time and things like that. We do that on a research basis of induced sputum studies and enrolling patients in a trial right now to look for progenitor populations of mast cells and eosinophils in the airway limit of people with asthma, and then correlating that with specific lung function criteria. So it's something that we're doing from a research standpoint in the lab, but it's not quite something that's a clinically relevant thing. Ram has set things up at McMaster where he actually got significant funding from his institution to basically set up a diagnostic lab where his lab actually provides the clinical results of the induced sputum testing, so that he'll get a percentage of yields in the induced sputum, and that will go in the patient's chart, and then he'll biobank the samples and use them for research purposes. Which is a wonderful system. Maybe if I'm here long enough, we can. I will see that.
Well, he's sort of unique in the world, I think.
Yes.
Yeah. Well, thank you for a great presentation. Any questions from the outside audience before we wrap it up, or any remaining questions in the room?
I have a question, but it might be a longer discussion question. Do you have any tips for when kind of the economic factors are a restriction for patients? Like we have a lot of patients where the history doesn't sound like it's asthma, but they just either aren't willing or aren't able to get pulmonary function testing. They aren't willing to come down and try like maybe inhale corticosteroids because they're all super like that. You know, those things for how you manage that.
Yeah, no, that's a great question.
Repeated, maybe.
Oh, yeah. So the question for the group online was, how do you approach the economic cost of performance in this diagnostic evaluation for patients with asthma, particularly as it relates to escalating or de-escalating therapy, performing pulmonary function testing? This is an important criteria that they mentioned in the ERS guidelines that I mentioned, that they didn't have providers on this committee from low resource countries where that's more of a prevailing issue, but it's still a prevalent issue in our country as well. In those situations, pulmonary function testing, sometimes the copay that people are paying on is quite astronomical. A patient just yesterday told me it was $1,000 for them to cover for their PFTs, which is mind-boggling to me. It does make me rethink and have pause doing this kind of, for everybody. In this case, the peak flow meters that I have are free and I hand them out. And so that can provide some things. But if a patient is actively using albuterol and actively symptomatic, and when they're symptomatic, they have peak flow rates that are normal, chances that patient has asthma, it's probably
I should know this, but PCD will also impact that, right?
Yep. It can, depending on things. It's a it's one of the most challenging things about the VCD and distal laryngeal obstruction, that it also, again, all you're measuring the peak flow rate, same thing with spirometry, you're measuring airflow. And if there's obstruction in the tubes that are kind of connecting, it's going to obstruct airflow, and it's going to reduce the flow rates. So can be tough. Inducible laryngeal obstruction is one of the most challenging things that I've encountered. I have a couple of patients that they've only been diagnosed after they've presented to the medical ICU and that otolaryngology do laryngoscopy while they've been actively symptomatic to define that they actually have significant change in the vocal cords where they're actually snapped closed and should handle it.
Yeah, I prescribed a lot of P-flows during the peak of the pandemic also because we couldn't do spirometry.
Yeah.
Most insurances are pretty good about covering it, but now you can get them on Amazon for like $20. And, just,
Peak flow meter.
yeah. I mean, and just what people appreciate just having the data and if they can just go to Amazon or someplace to get it, they're willing to do that rather than drive down to a teaching center and getting spirometry.
I don't want to be honest with us. I really like to use.
Yeah.
Same thing like we don't show people how to use inhalers. Number of people that I see with nasal sprays that jam it straight up their nose and put it up into the brain is too many to count. They've never been taught. We don't do a good job of counseling our patients. Sometimes just not enough time, but you really have to show them. I have them do 3 reproducible peak flow rates in the room in front of them.
So I was thinking if I could like show them in the clinic, I'd like to be more likely to use it, whereas all the times when I say, go get XYZ, it's just going to help you, I just rarely see them doing it. The population isn't able to do that or can't, but I just wondered where you guys got yours, because that would be a great thing to allow our friends to have.
Well, Ryan, and keep giving good talks like this. We're gonna invite you back.
Well, I appreciate it. I'm very happy to have just wanted to get to share this all. Actually, people who know me, it takes very little to get me talking.
All right, thanks again.
Yep. It's okay if I need the.
How many people do we have at a maximum on our outside audience? Let's monitor that.
26.
26?
Great.
Yes,